that feeling right? When a word is just, it's right on the tip of your tongue.
Oh, yeah. All the time.
You can picture the thing, you know that does, but the actual name for it is just gone.
It's so frustrating. But then, a second later, you snap your fingers and it comes back.
Exactly. But imagine if it didn't come back. Imagine that feeling was your new normal. And then, it goes a step further, you're not just forgetting the word keys, you're looking at them and you forget what they're for.
That's a terrifying thought.
Mm-hmm.
And it's so different from how we usually think about dementia.
Right. We think of memory loss for forgetting faces, getting lost.
But today we're looking at a condition where the memory can stay perfectly intact, sometimes for years, while the language part of the brain it slowly shuts down.
We're doing a deep dive into primary progressive aphasia, or PPA, and looking at this stack of clinical primers and diagnostic guides we have. This is not just some mild form of Alzheimer's. It's a totally different animal.
It really is. And our mission today is pretty specific. We have to be detectives here because PPA isn't just one thing. It's a syndrome with 3 very distinct variants.
3 flavors.
Exactly. And this is the critical part. If you treat them all the same or mistake them for standard Alzheimer's, you can actually do more harm than good.
Okay, that's a high-stakes hook. So we're going to break down who gets this, unpack those 3 variants so you can really hear the difference, and then we'll look under the hood at the biology.
And why that biology means standard dementia treatments can sometimes backfire.
Sounds like a plan. Let's start with the who, because I think the biggest misconception, and I was guilty of this, is that this is an old person's disease.
Right. You picture someone in their 80s or 90s. But PPA is actually considered a young onset dementia. The data shows the typical age of onset is in the 50s to early 60s.
That's incredibly young. That's when people are at the peak of their careers, maybe kids are in college.
Exactly. These are active people. And unlike some conditions, this one hits males and females pretty much equally.
So in the landscape of neurodegenerative diseases, how common is it?
It's rare, but it's not insignificant. If you look at the umbrella of frontotemporal dementia, or FTD.
Which affects the front and side parts of the brain.
Correct. PPA accounts for something like 20 to 40% of all FTD cases. So it's a major slice of that pie.
The timeline that the research describes is also, it's heavy. It's a very specific kind of decline.
It is. It's a slow burn. It starts, asymptomatically.
Yeah.
The damage is happening long before anyone notices anything's wrong.
And then
it moves into what's called mild cognitive impairment, but the non-amnestic kind.
Non-amnestic, meaning no memory loss.
Exactly. And that's the trap with PPA. A patient goes to the doctor, their spouse says he's struggling with words, and the doctor gives them a standard memory test.
Like draw a clock or remember 3 items.
Right, and they ace it. Because their memory is fine. They know what they had for breakfast,
Yeah.
so they get sent home told it's just stress or burnout.
And all the while, the language centers of the brain are deteriorating.
Precisely. From there, it progresses to prominent aphasia, major language loss, and often, eventually, total mutism.
Wow.
The average survival is about 7 to 10 years. But the research is clear that loss of independence, needing full-time care, that usually hits around the 7-year mark.
I saw one risk factor in the notes that was surprising. It wasn't the usual suspects like smoking or blood pressure. It said developmental disability.
Yeah, that's an interesting correlation. It seems that if someone had, say, learning disabilities or language issues as a child, maybe they were a late talker or had dyslexia, they might be at a slightly higher risk.
So like a pre-existing vulnerability in those brain networks.
That's the thinking, yeah.
Okay, so we have the profile. Younger onset, memory's fine at first, but language is just crumbling. Now let's get into that detective work you mentioned, the 3 flavors.
This is the absolute core of understanding PPA. They are so different, they almost look like 3 separate diseases.
All right, let's take them one by one. Variant number 1 is the semantic variant. This one, to me, felt the most unsettling.
It's profound. Semantic just means meaning.
Yeah.
And in this variant, the actual machinery of speech is fine. The grammar, the rhythm, it's all smooth.
Fluent, but empty.
Perfectly put. They're fluent, but the content is hollow. They lose the concept behind the word. The classic test is called confrontation naming. You hold up a spoon and ask, "What is this?"
And they can't say spoon.
Well, someone with a different type of aphasia might say, "Oh, for eating soup."
Mm-hmm.
They know what it is. They just lost the label.
Mm-hmm.
A semantic PPA patient might just look at it and say, Thing.
Or they default to a really general category. The example in the source was calling a watch a clock.
Exactly. Or they see a picture of a zebra and call it a horse.
Mhm.
And as it gets worse, that horse might become animal and eventually just thing. Their internal dictionary is just losing pages.
And this affects reading, too, something called surface dyslexia.
Yes. English has all these irregular words like yacht or so that you can't just sound out. You have to know them.
Right.
Semantic patients lose that knowledge. So they'll try to read so phonetically. As Sue, they can only follow the rules because the exceptions are gone.
There was also a behavioral part to this one that I found surprising. It's not just language.
This is a huge red flag for families. The atrophy is happening in the temporal lobes, which are right next to our emotional centers. So their personality can change. They can become disinhibited.
And the notes mention hyperorality.
It's a clinical term for basically putting things in your mouth. They might develop a sudden, intense sweet tooth or start overeating, sometimes even trying to eat things that aren't food.
So if you have someone speaking fluently but vaguely, and they're suddenly eating tons of sugar.
That is a neon sign pointing directly at semantic PPA.
Okay, so that's the loss of meaning variant.
Huh.
Let's switch to number 2, the logopenic variant. This one felt closer to what I'd imagine when I think of, say, Alzheimer's.
You are dead on. And a little spoiler for later, this is the variant that is most often caused by underlying Alzheimer's pathology. Logopenic literally means lack of words.
So unlike the semantic folks who talk smoothly, these patients are halting. They pause a lot.
Yes, the flow is broken. They have these long searching pauses. But, and this is the key difference, they haven't lost the meaning. They know exactly what a spoon is. They just can't find the sound file for spoon in their brain.
So it's an access problem, not a storage problem.
Perfect analogy. And the big clinical tell for this one is impaired repetition.
Like asking them to repeat a sentence back to you?
Exactly. If you say, the pastry cook was elated, a semantic patient can repeat that perfectly, even if they don't know what elated means. A logopenic patient can't. Their phonological loop, the brain's short-term audio recorder, is broken.
They can't hold the sounds in their head long enough.
Right, and they make sound errors. The example in the brief was saying baby flitter instead of babysitter.
They get the sounds scrambled up.
Yes, but notice they're still trying to say the specific word. They aren't defaulting to person. And their grammar is usually fine. They aren't speaking like a telegram.
Which brings us perfectly to variant number 3, the one where the grammar does fall apart, the non-fluent or agrammatic variant.
This one is, in some ways, the hardest to witness because the physical struggle is so obvious.
This is the telegraphic speech one, right?
It is. They lose what we call the mortar words, the little connecting words.
Oh.
To from the, is. So instead of I am going to the store, they might just manage go, store.
It sounds so effortful.
It's incredibly effortful. And they often have something called apraxia of speech. The brain knows what it wants to say, but the signal to the mouth gets jumbled. You can literally see their mouth groping for the right shape to make a sound.
But they still understand words.
Single words, yes. You say spoon, they can point to a spoon. But because they've lost grammar, they lose comprehension of complex sentences.
What's an example of that?
So if I say, the boy was chased by the girl, you need the grammar to know who was chasing whom. A non-fluent PPA patient might just hear, boy, chase girl, and assume the boy was doing the chasing because his name came first. They lose the syntax.
That's fascinating. And this variant can also progress to affect the body, right? Something about Parkinsonism.
Yes. This one is often caused by a buildup of tau protein, which can spread to motor areas of the brain. So as it progresses, patients might develop stiffness, falls, and tremors that look a lot like Parkinson's disease.
Okay, so let's recap the detective board. Semantic is fluent but empty, loss of meaning.
Right.
Logopenic is the pauser, loss of word retrieval and repetition.
Yep.
And non-fluent is the telegram loss of grammar and motor speech.
You've nailed it. That's the clinical map.
But this isn't just an academic exercise. Knowing the variant tells you what's actually happening in the brain. This is that syndrome versus disease idea.
This concept is so important. PPA is the syndrome. It's the collection of symptoms we see, but the disease is what's causing it.
It's like a fever is the symptom, but the disease could be the flu or an infection.
Exactly right. For PPA, there are two main diseases causing the syndrome: Alzheimer's disease and frontotemporal dementia, or FTD.
And the split is about 40-60.
Roughly, yeah. About 40 to 45% of PPA cases are actually just an atypical form of Alzheimer's. The plaques and tangles are just hitting the language center first instead of the memory center,
And that's almost always the logopenic type.
almost exclusively, which is
Yeah.
why those patients eventually start to look more like typical Alzheimer's patients.
And the other 60% are FTD?
Correct. And that's caused by different misfolded proteins, mainly tau and TDP43. And the correlations are spookily specific.
How specific?
If you have the semantic variant, there's an 80 to 90% chance the culprit is TDP43 type C pathology. If you have the non-fluent variant, it's most likely tau.
That's incredible. Just by listening to how a person speaks, you can predict the microscopic protein that's failing in their brain.
It really shows you how specialized our brain regions are.
Speaking of regions, if you put these patients in an MRI scanner, you'd see different patterns of damage, right?
Yes, and almost always on the left side of the brain because that's where language lives for most of us. You see this asymmetric atrophy, where one side of the brain is shriveling up.
Which explains why their visual memory or spatial skills might be totally fine.
Exactly. For semantic PPA, the damage is in the anterior temporal lobe, the brain's library. For logopenic, it's further back in the temporoparietal junction, the sound recorder. And for non-fluent, it's the inferior frontal gyrus, the speech factory, Broca's area.
The map of the symptoms is right there in the brain.
Okay,
So we've got the diagnosis, we know the variant, we even know the likely protein. Now for the hardest part, what do we do about it?
this is where it gets really tough. Because right now, there is no cure. There are no drugs that stop this from progressing.
And the research we looked at had a giant warning sign about the medications that are available.
This is probably the most practical take-home point from our entire conversation. Doctors with the best intentions often misdiagnose PPA as just dementia and prescribe standard Alzheimer's drugs, things like Aricept.
Which, for the logopenic variant, the Alzheimer's one might actually help a little.
It might, yes, it could give a small symptomatic boost, but, and this is a huge but if the patient has the semantic or non-fluent variant, which are caused by FTD, those same drugs can make things significantly worse.
Worse in what way?
They can ramp up agitation, irritability, that disinhibition we talked about. You're messing with the neurotransmitter system that isn't the primary problem, and it can just throw everything off balance.
That is just terrifying. A family tries to get help, and the treatment actually makes the behavioral problems worse, all because the specific variant wasn't identified.
It's what we call iatrogenic harm caused by the treatment itself. Same goes for the drug memantine. No evidence it helps, and it can make behavior worse.
So if the pills are risky and there's no cure, the management plan is mostly human.
It is. It's almost all non-pharmacological. The heavy lifting is done by speech-language pathologists, but the goal shifts. For a stroke, you're trying to rehabilitate speech. For PPA, you can't. The goal is compensatory.
It's about finding other ways to communicate.
Exactly. It's about communication, not speech. Can we use an iPad with pictures, communication boards, hand gestures? It's all about keeping that person connected to the world as the bridge of language falls apart.
And supporting the caregivers through that.
Absolutely essential. Because the family needs to understand this isn't my wife being cold and rude. This is her anterior temporal lobe failing. That reframing is everything.
We've covered a ton of ground here. From just a few missing words all the way to these three very distinct paths of losing meaning or retrieval or grammar.
And the biology that underpins it all.
It's a heavy topic, for sure. But I feel like understanding the why and the how takes at least some of the fear out of the unknown.
Knowledge really is the best tool we have for this right now.
I want to leave you with one final thought that's been bugging me since we talked about the semantic variant. We talked about losing the meaning of the word clock.
Right.
So if you lose the word clock and then you lose the whole concept of what a clock is, a tool to measure moments passing, does your actual experience of time itself change?
That is a deep, deep question.
We assume language just describes reality. But what if, to some extent, it constructs our reality? If the word love or justice or tomorrow gets erased from your brain, do you still feel those concepts?
It really challenges what it even means to be conscious. If the scaffold of language collapses, what happens to the building?
Something to think about. Be thankful for every word you can find. Thanks for listening to The Deep Dive.